Welcome, everyone who's joined us in the room and online. We thank you for choosing to be part of the annual Alice P. Lin Memorial Lecture. My name is Melissa Begg, and I have the great honor of serving as Dean of the Columbia School of Social Work. Launched in 2020, the Alice P. Lin Memorial Lecture gives us an opportunity to hear from leaders in public policy and administration as they explore how policy shapes well-being for individuals and for communities. The Lin Lecture and the Lin Doctoral Scholarship were created by Dr. Nan Lin to honor the memory of Alice, his wife of 48 years. Alice P. Lin was born in Chengdu, China, and raised in Taiwan. She immigrated to the U.S. in 1964 and received her master's degree in social work from the University of Michigan, where, in her own words, she was stimulated and challenged to think beyond her immediate concerns. She earned her doctorate from Columbia School of Social Work in 1985. After completing her doctorate, Dr. Lin enjoyed an illustrious and an impactful career in social welfare administration. She served as Deputy Commissioner for the New York State Office of Mental Health, as a professor at Duke University's Fuqua School of Business, and as a consultant to governments across the country. She was a proud Columbia alum, and her service to the school includes 8 years on the Dean's Advisory Board. Dr. Lin published a memoir before her untimely passing in 2015. I was going to give a quote from it, but I learned from Dr. Munson that she plans to quote from it as well. So I'm going to leave that to you. And just to say that I believe her memoir really focuses and underscores collaboration and centering humanity in all of what we do. And I can't think of a better sentiment to this point in time. I'd like to acknowledge Dr. Nan Lin, Dr. Alice Lin's husband, for his generosity in establishing this lectureship. I believe Dr. Lin is joining us online, so thank you for making this possible for us. So now it is my pleasure to introduce the moderator for today's event, my wonderful colleague, Dr. Ana Abreu-Lanza. She's professor of social work and vice dean of our school. She's a scientist who's cross-trained in the social sciences and in public health, is a leading scholar in Latinx health and behavioral science, and an innovator in curriculum development, and an effective advocate to diversity, equity, and inclusion in the academy. Dr. Abreu-Lanza was previously on the Columbia faculty before this stint from 1998 through 2018. When she left to pursue a senior administrative leadership and faculty role at the NYU School of Global Public Health. Now, while at NYU, despite that heavy role, she maintained an active program of research focusing on cultural, psychosocial, and structural factors that affect the health of Latinos, and in particular, how ethnicity and culture, especially acculturation processes, relate to health beliefs and behaviors. A major focus of her research is on analyzing health disparities and exploring key cultural, social, and individual factors that promote health. Notably, her work on the Latino health paradox is widely cited, and she's maintained a deep commitment to recruiting and retaining a more diverse faculty and student body in every institution and in every role that she has filled. So thank you for that, Ana, and it's a pleasure to turn it over to you to introduce our guest speaker.
Okay, good afternoon. It's such a pleasure to be here to introduce our honored speaker. Dr. Michelle Munson is professor at NYU Silver School of Social Work, and she is an internationally recognized expert in mental health services and interventions for adolescents and young adults. She's also the director of NYU's Silver School's Youth and Young Adult Mental Health Group. Her research is situated at the intersection of mental health services research and positive youth development. And recently, she has focused on developing and testing of engagement and treatment interventions for young people with serious mental health conditions. Her overall program of research really does seek to understand how society's structural conditions and social relationships through both verbal and nonverbal communication shape young adults' decisions to seek or not to seek professional mental health services. Her research and scholarship also seeks to develop, refine, and adapt and to test engagement and treatment interventions for adolescents and young adults with serious mental health conditions. Her intervention programs use very innovative and empirically based communication strategies to capture young people's attention and engage them in their care. And this includes dual provider teams that integrate social worker and a peer. The programs also rely on modalities that youth favor and that facilitate mental health conversations. And these include things like narratives or stories that surround mental health topics. Her research centers very much on the perspectives of youth, their families of choice, and their providers. And she does this to develop services and interventions that match the views of those who actually use them. She is a highly regarded colleague. She has provided consultations to mentoring researchers, policymakers, program designers, and mental health service intervention researchers. She is widely regarded also by the National Institutes of Health, where she has served as an expert reviewer on grants, also by the National Science Foundation and the William T. Grant Foundation. She was also an invited reviewer for the Institute of Medicine state-of-the-art report entitled Investing in the Health and Well-Being of Young Adults. Her research has been widely supported by many entities, including at the federal, state, and the local levels. She is also a widely published scholar. She also serves on the editorial boards of Emerging Adulthood and the Journal of Adolescent Health. And she earned her PhD at Washington University in St. Louis and her MSW at the University of Minnesota Twin Cities and her BA at the University of Wisconsin-Madison. Please join me in a warm welcome to Dr. Michelle Munson. We look so forward to hearing your talk. Thank you again.
Thank you. That was so lovely. So thank you for that wonderful introduction. And I want to start by thanking Dean Melissa Begg for this invitation to come uptown and share about our work here in New York City. I also want to thank the Lin family for the opportunity to share our work and to honor Alice Lin. And finally, I want to thank each of you for coming today and spending some of your afternoon, whether that's online or here with us in person. Okay, so I want to begin by acknowledging Dr. Alice Lin. Indeed, I was moved by this quote by Dr. Lin. She says, "The very survival and growth of humankind depends on how the races and nations live and work together, and how men and women learn to share the same dreams." And I think these very sentiments are so important to the world we are living in today, a world where it is difficult to live and work together and even consider the idea or imagine the idea of sharing dreams together. What an important statement for reflection about our survival and growth as humans. The work that I'm going to share today, thank you for mentioning our youth and young adult mental health group at NYU, has been done in collaboration with a number of different scholars. And our mission at the Youth and Young Adult Mental Health Group is to understand the transition to adulthood among socially and economically marginalized populations of youth and young adults and learn how to make their transitions more successful. And this image that you can see with a few people's heads cut off is from SWR, just this past year, SWR 2025. And I wanted to also acknowledge these scholars who are a big part of our team and doing the work that we do. And specifically, I have had the distinct privilege and honor of working with a number of alums of the Columbia University School of Social Work. And what a force for good they are. So my lecture objectives for today are to tell you a little bit about my background and how it influences my epistemological position and the way that my colleagues and I think about the work that we do. Then I'm going to talk a little bit about why young adulthood. Why are we focused on the transition to adulthood in our work? And then I'm going to spend time, as Anna said, talking about developing and refining psychosocial interventions for these young people that we've been working on for the better part of a decade. I'm going to share conceptual scholarship that grounds the work that we do, and then talk about an engagement program that we've been developing for over a decade, and talk about treatment programs for this population. And then I will end talking a little bit about future research, social work practice, and policy. However, I want to start by making sure to share a bit about my background and experiences which shape how I approach my work and the work that I'm committed to as a social worker. So first, I identify as a white middle-class, cisgender, lesbian woman. And perhaps less obvious, I also identify as the daughter of a war survivor, a first-generation high school student on my mother's side who had to stop her education in the 8th grade to work and help her family. And importantly for today, a person who has benefited from many of the programs and services that I research. And this is important as I often possess both an insider and outsider position on the studies that I conduct with my colleagues. And I think a lot about that in the work that I do. So I want to share and ground this lecture briefly by explicitly naming my guiding epistemological position. So when I was trained many moons ago at Washington University in the early 2000s, the dominant social work scientific position on knowledge production was objectivism. The idea that meaning exists within an object and that there's one objective reality. And a lot of that foundation in my scientific training was steeped in deductive reasoning and prediction. And that was really important training that I received at that time. A little later in my career, early on as an assistant professor, I was invited to work with a more senior colleague who trained me in qualitative methods and began to help me understand the value of subjectivism and really considering meaning as it exists within the subject and how the subject can impose meaning on the object. And we used a lot more inductive research methods in that work. And so now in my work, I identify as a pragmatist, and this chapter by Susan Kemp and Gina Samuels really speaks to the current sort of position I have in thinking about social research. And they say, all necessary approaches should be considered and utilized in trying to, change an issue that you're passionate about or build knowledge and build science. So I often use mixed methods, kind of bridging these deductive and inductive reasoning, and I often integrate these different data sources to be able to generate inferences and results that are grounded in really the strengths of both quantitative and qualitative methods, which you'll hear about today. And to take that one step further, more recently, I've been deeply impacted by the writing of people like Fricker, Dotson, Samuels, and others on epistemic justice. Anna and I had a talk about a presentation we did at SWR on some of this work over the past couple of years. And this discussion suggests that testimonial injustice, one type of epistemic injustice or oppression, or as Dotson would call violence, epistemic violence, occurs when people who hold certain identities actually lose credibility as it relates to being a knower and being somebody who can actually build new knowledge. And our team at NYU thinks a lot about this body of work and about this idea about whose facts matter, about who gets to decide what is true and what is true for whom. And we often talk quite a bit about, do people with lived experience, not any lived experience, but lived experience as it relates to the research question or the topic under consideration, actually have a place at the table? And does what they bring truly hold value, or as we often talk about, or are they being involved in more of a tokenist way and sort of trying to think about and challenge ourselves in thinking how it is we're partnering with communities and different collaborative partners? So I want to now transition to the question of why young adults and why focus on the transition to adulthood. And I want to start that out by telling you about Raphael. And Raphael was a client on my caseload when I worked in the 90s at Elmhurst Hospital. And this was a client who was found in Penn Station without identity, any identification on him, didn't speak English, but he showed up to our hospital and was experiencing psychosis and a tremendous amount of fear. And Raphael was admitted to the adolescent unit where I was working. And he remained there for a long time. And he began to get better over time, attended all of our different, groups and started to be, more comfortable and less afraid on the unit. But what happened with Raphael is a microcosm of what happened to a lot of my clients, which is that the hospital administration, keep in mind, he didn't have identification, but it was thought that he was 18 or older at some point and that he needed to leave the adolescent unit. And so I had to walk him over to the adult unit in the hospital. And this, as I said, happened with many other cases where we knew, in fact, it was their 18th birthday and we had to bring them over to the adult unit. And in many of these cases, I observed people who had been doing better, feeling better, suddenly taking steps backwards, or we could say regressing, because they had to go onto a unit that didn't feel relevant, that didn't feel like they were able to meet the client's needs. And so I became very curious about that and wanted to think more about that as I pursued a PhD. And further, epidemiological data has long documented that among adults, the young adults who are represented here by the top line, if you can see color, the green line, which appears on the top of these figures. And over many years, the National Survey of Drug Use and Health has looked at the rates of mental health conditions among these different subgroups of adults. And so the young adults, 18 to 25-year-olds, you can see on the figure on the left, hold the highest rates of any mental illness in the past year. And you can also see on the right figure, while it is decreasing, this is the figure on serious mental illness, it is still the highest level of prevalence among the young adults. And so that's concerning in and of itself. And then you add to the picture, this is also from SAMHSA's National Survey on Drug Use and Health, this important figure that my colleagues and I look at most years, which is on perceived unmet need for treatment. And also depicted in green are the young adults, the 18 to 25-year-olds, who are, as you can see on the left, the highest group for perceiving an unmet need for treatment. And among those with serious mental illness, that's close to 60% of those with a serious mental illness. And perceived unmet need is defined as perceiving a need for care or actually seeking help, but not receiving it in the past year. And so this is really concerning, right? And so you can hear it from cases, and we can hear it from the data that we have nationally. And importantly, over the years, we have also learned that there's particular subpopulations of young adults who have extremely elevated rates of mental health needs. And I just am pointing out here two of those subpopulations. Young adults aging out of foster care, the rates are reported to be 2 to 4 times higher than their peers. They have higher rates of suicidality and lower rates of continued engagement in services. And then you see among youth and young adults unstably housed, over 2/3 of homeless youth and young adults have actually met criteria for a mental disorder, along with studies, again, documenting this low rate of service utilization. So there's a lot of reason to care about young adults. And finally, the current moment we are living in will only exacerbate these concerns. And the Urban Institute recently published an important report suggesting that 3 out of 10 young adults are at risk for losing their health care due to Public Law 119/21. And they spoke about 5 specific reasons that you can see listed here. Perhaps none of them will surprise you. Things like increasing more paperwork, having shifts in work reporting requirements, leading young adults to lose coverage, higher out-of-pocket costs, Medicaid changes, reducing young adults' access to health care of all different sorts, and actually removing incentives for particular states. And so all of these important situations are potentially going to make this situation a lot more difficult. And that's what we're dealing with today in considering these questions. So I want to transition now to talking about developing and refining psychosocial interventions for young adults, and talk a little bit first about formative work that I've done and really grounds our interventions in the work that we do. And the first conceptual scholarship I want to just present very briefly here is simply to share with those of you who don't know much about the field of the transition to adulthood. In the 90s and early 2000s, this 18-year-old sort of arbitrary age cut young people from resources and services across pediatric and children's services. Raphael was one case in the hospital context, but this was happening in child welfare and other services as well. And thanks to the work of many scholars over the years, the very, very hard work, that 18 point has become a softer, less abrupt transition. Service systems have put in resources to develop preparation programs earlier in adolescence, and then services have been allowed to continue. Transition age youth programs have emerged beyond 18. And I wanted to share White and Cooley's classic paper from pediatrics just to belabor this point. This is specific to medical homes, but you can see in this figure that transition is now beginning to be considered in policy and programming as young as 12 years old. And that systems are really continuing to help transfer care to adulthood as old as 26 years old. And that's a really big shift and change. And while the systems have changed, which is really good news, and have become more responsive and more elongated, transitions to adulthood have been able to occur, large numbers of transition age youth still stop using services. And when I was coming out of my training, I was part of a program that published a study that showed that the month before young people left foster care to the month after they left foster care, 60% of them stopped using their mental health services. And this was a very alarming moment for many of us, because nobody had really done the work to try to understand the reasons for that. Now, we knew a lot of that had to do with losing insurance, losing important resources and supports, but perhaps there were other important reasons. So this led to an important formative study that I did actually in the state of Ohio, where we went out into the field and we talked to those young adults. And we sampled young adults with mental health conditions, both who were continuing their service utilization and who were not. And we sat with them. It was a mixed method study, so we had a lot of an opportunity to just have a conversation and hear their narrative, their story about why they weren't continuing with services. And I just want to point you to, this was the conceptual framework that came from that work, which pointed to community factors, social factors, and an important set of individual level mediating factors that continued to emerge in these interviews. Behavioral beliefs emerged, like young people saying, I don't really think these services that I've been going to during my adolescence are helping me at all. In fact, I can get the same kind of help on the street. Also, stigma emerged as a significant concern for young adults, along with emotions. Common emotions were coming out of these 60 interviews, emotions like fear. And fear actually, interestingly, was both a motivator for some young adults to seek services and also a deterrent. And then self-efficacy. And so this work led us to begin to think about what are some of the ways we might be able to change those important thoughts and emotions. A second body of conceptual work, I did a review paper with a mentor of mine to begin to think about, well, okay, these are some of the things that we might need to change. Well, how should we communicate with young people in our programs to make these changes? And so we reviewed the literature and this conceptual framework. On the left-hand side, you see learning theory, often attributed to Albert Bandura, that if you're going to learn, you have to attend to something, comprehend it, accept it, and then be able to retrieve it in the moment in your life when you need it. And then on the top side, you see classic top-down communication theory, where it's important to think about your programs and who's the source of the information. What are the messages? What's the context? What's the channel? And who's the audience for the program? And so what we learned from the literature and some of our pilot research was that we wanted to think about, and as we developed interventions, make some decisions based on what young people were telling us, that they might attend more closely if the sources of information were people they were attracted to or they thought were credible, like artists depicted here, many, Lady Gaga in the center. We also learned from young people they really love talking about their mental health through music. This was repeatedly reported in our interviews. And so we thought about and wanted to test whether having part of our intervention programs provide an opportunity for young people to speak about music lyrics that revolve around mental health. Sidebar, I started doing this work, as I said, in 2005, and there was a publication in JAMA specifically on mental health content in music lyrics. And the, figures showed it has just skyrocketed. When I began, there were few artists talking about mental health in their music lyrics. We also learned from young adults, they want to talk about their mental health in groups. And so maybe the context we should consider is group work. Also, this channel of having opportunities to create space to just hear different narratives from individuals. This was a body of work we found in our review out of cancer, that oftentimes people are less resistant to hear and learn new information when it comes through stories. And so we thought, well, let's build upon that and use tech narratives around mental health. And lastly, you want to consider who your audience is, obviously. And so we wanted to think about whether or not young people might accept, and there's some data to suggest accept messaging from people who have similar experiences than them, similar lived experiences. And so we had this peer provider who was part of our hybrid team. Thirdly, I want to talk about the scholarship of experimental therapeutics. And this original study in World Psychiatry by Thomas Insel began to push the field to say, we're no longer going to just study interventions and whether they change outcomes. We need to set up our designs of our studies to articulate those key mechanisms of action or mediating targets. What he said that was so exciting at the time was this allows us to utilize our negative efficacy data, which can be informative, both telling us as interventionists, or in his case, physicians, that we have to go back and rethink our intervention strategies because they're not hitting the targets, and or we may need to change those targets or mechanisms of action. And second, if you set your designs up this way, it allows you to test the importance of a target. So if the target is not actually correlated with the outcome you're interested in changing, perhaps you need to actually shift and change those targets. And so my colleague, Dr. Ramesh Raghavan, and I, and our doctoral students have written 3 papers bringing this scholarship into social work. And this is an image from one of those studies in a paper where we started calling this the science of how. So not if an intervention changes an outcome, but how. And so this just depicts an employment intervention and those primary main outcomes you may want to be considering, but can you measure all those targets that you think need to change in order to increase job stability or financial resources? And so now I'm going to share with you a little bit about Just Do You, which was the name of the intervention that I've been developing over a number of years and in a few different contexts, which is an early application of experimental therapeutics. And one of the main innovations of Just Do You is that this was a decision when we wrote this grant that we didn't want to situate it in the child or pediatric side of services. We wanted to situate it on the adult side because at some point, whether it's 18, 19, 21, 23, these young people are going to transition to adult services. And so we wanted to see if we could make an impact on the adult side of services. And so these are just some images that I wanted to share because it's really important to note that this intervention program has been designed, as I said, over many, many years, many iterations. It started as a 12-session engagement program, and now it's a 2-module engagement intervention. And the content and the strategies have evolved over the years, and these are many of the people, both in the communities, and then also in that larger picture, it's important we brought communities into NYU as part of a learning collaborative to talk about some of the different intervention strategies and what people thought about those programs. So we consider Just Do You to be a meta intervention. So what do I mean by that? I simply mean that if we found any promise in this brief 2-module program, in our research, perhaps it could be utilized before any number of evidence-based treatments, because Just Do You is not a treatment. It's an engagement program where we want to help young people show up to the treatment or show up to the program that is an evidence-based program. And so we were lucky to get a grant to study this program in a specific context with OMH's personalized recovery-oriented services. And this is their model for adults with serious mental illness. And it's steeped in evidence-based recovery and rehabilitation approaches. But what we wanted to do with Just Do You, we situated it in the intake period. So when a client was coming for PROS, often they're leaving hospitals or jails and they're told, you're going to begin this PROS program. So we wanted to see if young adults who received our modules would be more engaged in the larger PROS program. And so what I want to share in this image is our conceptual framework, which I hope you see aligns with experimental therapeutics. And so what we have here are the 5 major intervention components that are part of this program that, as Anna said, is facilitated by a hybrid team of a social worker and a peer or person with lived experience who we call a recovery role model. And it includes traditional psychoeducation, the use of music and music lyrics, peer support, providers who are often considered mentors to the young adults, and then these tech narratives, and then visual arts and poetry. And those mechanisms of change, they came from the formative research. These were the things the young people told us were influencing their decisions to show up at services. And so we wanted to look at engagement and recovery outcomes. And this was a 2-group randomized clinical trial. We enrolled 121 young adults in the Just UU program at intake of 4 different PROS programs in New York City. 2 in Brooklyn, 2 in the South Bronx. And our main measures were 2 measures of engagement in the larger recovery program PROS. We looked at attendance in the past 2 weeks. And then an innovative measure that came out of child welfare, actually, that allows you to measure level of involvement in the program. Not just if you show up, but how involved you might be when you show up. And then we wanted to measure those key mediators of interest. And so our analysis used traditional single degree of freedom contrasts and some regression. And then for looking at these mediators and their relationship to the primary outcomes, we used correlations at 3 months post intervention. So just to share a few results from this trial, some key findings. In this first slide, you can see here that the young adults in the Just UU program, in fact, were significantly more engaged in Just UU as it related to that level of buy-in or level of engagement when they were at the program, which is a continuous measure. Attendance wasn't statistically significant, but it was trending in that direction, that they also attended the program more than those who did not receive the engagement program. And this figure shows this important set of analyses we did on the mediators. And so we found that the youth or the young adults in the Just UU program were about 5, they scored about 5 points higher on our measure about behavioral beliefs about treatment, specifically the PROS program, than those who didn't receive the engagement program. And what you see on the right side of this figure is that that target mediator was significantly correlated with our outcome of interest, which was equally important information. If it changed behavioral beliefs, but they didn't matter, then that's important information for us moving forward. And I want to just share, this study was published in the Journal of Adolescent Health. We did find that we were able to move the needle also on the young adults' beliefs that their providers at PROS were credible and trustworthy. And also, they scored lower on stigma, personalized stigma. But we weren't able to change other important mediators: hope, self-efficacy, and those important emotional reactions to treatment. And that's also important information for us to know. Finally, while this particular NIMH grant wasn't aimed at looking at recovery outcomes, we did measure them. And what we found is, after controlling for recovery at baseline, those in the Just UU program, in fact, had higher scores on personal recovery. This is items about their future, their goals. And what we found that was interesting was that change happened through their engagement in the PROS program. particularly their level of involvement when they showed up. Not if they showed up, that path was not significant. It was how involved they were when they showed up at the program. So I just want to highlight, there's a couple of current trials going on of Just Do You. My colleague and former postdoc, Dr. Kiara Moore, proud alum of the Columbia University School of Social Work. It has a K award, and she's adapting this program for racial and ethnic minority young adults and is testing it in Mount Eden Pros, which is in the South Bronx. Here she is with her team. And importantly, she's developing specific components we didn't have in Just Do You that we hypothesize might change hope and might change some of the things that we were not able to change. And there's also a group in Nova Scotia who have adapted the Just Do You program in an early psychosis program. Those were also some places that we've done trainings on Just Do You. So I want to shift gears and tell you a little bit about a treatment program for transition age youth and young adults that we've also been investigating. And this work started really because of two things. One, the National Council of Behavioral Health contacted me about this program, Cornerstone, which they were investigating in Detroit, Michigan, and asked if I would be interested in coming to Detroit and learning about it and potentially writing a grant to evaluate it in a future study. And so that was an invitation to become part of this. I did not develop Cornerstone. This was somebody else's model. And then at the same time, Assistant Commissioner Nancy Hollander from up at OMH was putting together a group of scholars to think about what do we know about the evidence base for treatment models for transition age youth. And so we came together and we looked at the US-based models, the effective models, there was about 16, and we found there were common components to all of these treatment programs. To some of you, this may not be a surprise. Team-based approaches, they included case management, centering lived and living experience, family involvement, and often they had outcomes around education and employment. So what is Cornerstone? This is an image of our team in Brooklyn. I'm pausing because Tiffany Rasmussen is in that picture, who I believe still works here in continuing education. So what is Cornerstone? Cornerstone is a theoretically guided, promising multi-component intervention for addressing mental health and developmental needs of transition age youth. It was provided for up to 9 months, and it was embedded in a local agency, and it had 4 main components to this model. Again, it had a hybrid provider team of a social worker and a peer, who we called a recovery role model. And we called the social worker a boundary spanning case manager. And that's because we were going into Article 31 clinics, and we were training social workers and inviting them to be part of a program where they had to leave their office. And it wasn't about 45 or 50-minute sessions in the clinic. It was also about going out into the community and meeting their clients, whether that was in school or a hospital. And they were doing this work at the same time. And so they were sort of spanning those boundaries. But it included counseling based in trauma-focused CBT, critical time intervention, and peer mentoring. And this study was funded through an R34 mechanism that was really aimed at understanding feasibility, acceptability. And so I just wanted to share a couple of those outcomes. We enrolled 56 transition age youth in this program. We recruited 81. And then one of the questions was, were we going to be able to randomize these transition age youth? And we were able to randomize 29 into Cornerstone and 26 into treatment as usual. And that did involve, conversations with parents about that process. And we had to sort of get a sense of whether we would be successful at that. We also, related to supervision, found that what was really important for this model to be successful was supervision, and supervision on multiple levels. And so we found that we needed supervision for the boundary spanning social worker, clinical supervision, also peer supervision for that recovery role model, and then the need for a team-based model on a weekly basis where we came together to discuss cases. And so here you see a quote from one of the clinicians saying, "I think supervision was very effective. It helped me to be able to explore options outside of my box, especially being that Cornerstone gave us more options to re-engage the client. And my supervisor would help me think, okay, this is another option that you can explore with this client that we wouldn't be able to do at the clinic. Just go out to the home if you haven't heard from the client in a while. Let's see if we can get the parents involved." So again, we were able to maintain a lot of these young people because the social worker not only could, but they were sort of charged to go out and help the clients remain in contact and in touch, as opposed to what often happens in clinics, many of you may know, which is if you don't show for a couple sessions, your case is closed. We also had some interesting themes emerge on acceptability, the acceptability of being able to extend services into the community, the use of peers, and just general helpfulness we heard from youth. But I wanted to highlight this acceptability theme around the use of peers. And one of our participants says, "I think that the mentors are able to connect with the clients on a different level from us. They can share their personal experiences, and just listening to my clients, I could tell that they really appreciated that. They felt like there was someone that they could relate to. Some of their experiences were normalized." And for those of you who have worked in these contexts of a feasibility trial, there's this debate in the field about whether you should be looking for change in outcomes, but then they tell you, no, you shouldn't be. And then they tell you, but yes, you should look for a preliminary signal. So we, in fact, did look at some outcomes for this study, even though we were primarily focused on feasibility and acceptability. And we did find a couple of important within group outcomes, just looking at simple statistics at pre and post on mental health, stress, and recovery only among the Cornerstone youth. And we found there were positive changes from baseline to 9 months. And then between groups, we did find at 9 months, there were more transition age youth involved who were in Cornerstone than in the treatment as usual group, perhaps signaling that Cornerstone may promote engagement. And lastly, related to implementation, we embedded interviews to talk with different stakeholders about this model, about the different aspects that we may need to address if we want to consider scale up. And so I'm sharing just a couple of quotes about the outer context. These are terms from a common implementation model called CFIR. And this is an area where we were really challenged, and I would even go as far as to say we failed to be able to document enough to be able to scale up this program. But you hear from one clinician saying, what we do at Cornerstone requires more time than what we typically do at the clinic. In vivo, for example, the time that I spend traveling with the clients, would that be compensated for? And then you hear the clinic director saying, I don't know the full extent of Medicaid redesign, but from what I do understand about it, some of these non-billable services that we're doing as part of Cornerstone might be paid for. And they were referring at that time to the peer services, which I will say that is one area where we have been able to shift the needle and get more peer services reimbursed here in New York. Another important final outcome to share is that in Cornerstone, the groups were a serious failure. So I'm a group worker, and I thought, wow, these skills-based groups are going to be really important for the young people. And we offered them at night. We tried so many different things, but the young people didn't come. And when we talked to them, they told us, I'm happy to meet with my recovery role model, my social worker. However, these groups in the evening, I'm afraid I'm going to run into my high school classmates, or there was real stigma and concern. And so moving forward, we consider in these group-based transition age youth programs that perhaps group-based approaches are not the best. So these are a few studies that are currently going on that embed some of the aspects of what we learned in Cornerstone. Charge Up is an R34 out of Houston, Texas, embedding critical time intervention among many other elements, along with a peer they call a transition specialist. I'm also a co-investigator on a grant in Cleveland, Ohio, where I came from, called Youth Empowerment and Safety, which is addressing LGBTQ youth suicide. And it's really focusing on a lot of what we learned around peer support and actually how to make peer providers safe in the process of disclosing lived experience. And I'm a co-investigator also on a program in Massachusetts called Bright, which is in the context of high schools. And that's using a lot of comprehensive care coordination and peer leadership. And finally, I'm happy to say just last week, we submitted an R01 to take some of this work into the context in New York here of supported housing for young adults. And we're looking at some components that are similar to Cornerstone and some that are quite different. So I want to transition lastly to some thoughts I have about where do we go from here that hopefully we can talk about in the Q&A as well. So I'm thinking a lot about technology, targeting, the science of how, and our profession, and sort of where we are in this moment. And so this image related to technology is actually from an R01 we did write for Cornerstone, which was scored but never funded. Welcome to grant writing world. But I have questions around so many questions around technology right now as a social work professional. And my colleagues and I are thinking about how do we balance technological advancements and our clients' needs for human connection. The youth, but also the parents, but also the communities, et cetera. Do we create tools? Do we integrate tools with face-to-face? Do we use technology for certain conditions? And think about other young people who might be suffering with certain conditions or complexities where coming into a building, a brick and mortar building, is an important part of the treatment. How do we think about that? How do we move forward in this moment? And in the next quarter of the 21st century, how can we leverage findings from these in-person studies to build effective, cost-effective, and safe technology-based programs and modules? I think that's so important, and I know social work has a lot of great leaders doing work in that space, and I want to keep thinking about that as well. In my lab, we're also thinking quite a bit about targeting. How do we make the most of limited resources? And, I'm considering that a lot, again, within the current policy movement, where all of our services are being slashed, our organizations are facing so many cuts. And so we're thinking about questions, are some interventions universal for agencies and community-based organizations, while others may be able to be targeted based on community need? And how can we use data to figure that out? Might it be that some communities are facing more of a need around stigma, while others, it becomes evident that there needs to be programs around parent education? And so I'm thinking a lot about that. And I just briefly wanted to share some high-level results from a study that was funded by our Constance and Martin Silver Center on Data Science and Social Equity at NYU. We colloquially called Hotspots. And this was a partnership with OMH and at the time, the Langone School of Medicine. And we were looking at geographic locations in New York State where there was the highest level of need. And we brought together New York State Medicaid claims data, data from the Economic Innovation Group, New York Department of Homeless Services data, and HRSA's Area Health Resource File to come together and help us answer questions and learn about prevalence of young adult serious mental illness and service use. And so we were able to look at the claims of over 1.5 million young adults, and we found that the prevalence of serious mental illness was about 8.3 among young adults in New York State who have Medicaid. And we found that a couple of the key predictors were young adults who had experienced homelessness had a much higher prevalence rate than those who didn't, and also those living in rural zip codes. And so we also utilized visualization data with our colleagues at OMH to begin to look at small area variation of serious mental illness prevalence by zip code. And what these figures show is that when you're looking at New York State, you may not be able to read this. The darker red zip codes are where there's higher prevalence of serious mental illness. And when you look at the whole state, you may notice that New York City doesn't have any darker red areas. And I think this points to the importance of, right, how are we thinking about the design of these studies? And so we looked both at the state and the city. And when we only looked at the data in the city, there were some key communities, many of you I'm sure can identify them, where there was indeed higher prevalence of serious mental illness among young adults receiving Medicaid. We also found, this is some work being led by Deborah Lehman, who works at OMH. This is from our SWIR presentation, that housing and rurality were also important as it related to service utilization. And we found that those living in rural areas were more likely to have an outpatient visit and an inpatient visit than their urban counterparts. And those who were unhoused were less likely to have a follow-up visit after inpatient hospitalization, and they were generally more likely to use crisis services. And so our team wants to think about potential state-level policies that could consider more of these social determinants of health, housing instability, and also think about rural versus urban and try to dig a little bit deeper to understand these results. And perhaps try to think about geographic variation and how it can help us reveal certain areas where there might be elevated need so we can better target our limited resources. And so the next steps of this work, which we're really very interested in at this time, is we're working with our OMH partners to go into these rural zip codes and do qualitative work to dig deeper beyond these prevalence rates and predictors of service use to really try to contextualize the findings, to understand mental health need. What does that look like? What are the risk factors? And where are the availability or service gaps, in particular rural areas? And then we recently got a new grant funded by the Trinity Foundation to continue this work in Lower Manhattan, working with 11 neighborhoods in Lower Manhattan to begin to survey youth to try to understand their pathways to care, and also, again, be having a focus on youth coming from different neighborhoods and actually, collecting the data on the neighborhood so we can potentially tell executive directors or leadership at organizations, what might be the particular services and interventions they might want to offer for their community. I also just want to mention that I'm very excited about this science of how. I want to continue to develop and test interventions with colleagues who are interested in trying to understand and design studies where they can leverage knowledge when specifying and measuring these target mechanisms. And also, I'm really excited about training the next generation of scholars to want to do the same. And I just put the listing from the PAR that we recently applied to because I think it's really important to note that a lot of our funding agencies, including the NIH, are actually requiring this framework now, that you must identify these mechanisms. And lastly, before our conversation, I'm thinking a lot about the profession and how fast it's going. I think about this every day. I think about just the speed with which we're changing, practice settings, practice approaches, our incorporation of AI technology, smartphone applications. And I'm just asking myself, and maybe we can talk even today, what can we do as a profession to bolster the guardrails, to maintain safety, build substance and novelty of ideas, and sustain that human connection, that I mentioned at the beginning that Dr. Alice Lin was talking about. And I was very heartened recently to see our colleagues from the APA had success. Their advocacy recently actually led the Federal Trade Commission to begin to investigate AI, the chatbot cases that we've been hearing about so much. So I know social work is at the table. How can we continue to be at the table and be thinking about, these questions as a profession? And so that's all I have to say. Thank you so much for listening.
That was wonderful. Thank you so much for your
Thank you.
comments and for sharing with us your findings from this very important program of research that is just so timely. I think we all know there's a mental health crisis in the United States and globally, as you have shown, and it's so key to think about young people experiencing these severe mental illness and other conditions and what we should be doing to address this issue.
Thank you.
We're
so
going
much.
to take questions from the audience momentarily, but while you're thinking of questions, I'm going to get started with a couple. So you've presented this amazing program of research and the findings that have inspired you to learn more. Did you start your career with this particular trajectory in mind? Was it something that came up as you were finding new things? Can you just tell us a little bit more of that story, how that happened?
Sure. Thank you so much for that question. So the answer is sort of. So I mean, I was interested in the transition to adulthood very much, as I shared from my clinical work at Elmhurst and at my later positions here in New York City. But really, I went off to graduate school to study a concept that I was very interested in. It's now commonly discussed. This is what we call first episode psychosis, but this was 2001. And I was reading about this compelling work in Australia and Canada and the UK about attempts to reduce the duration of untreated psychosis. That's what they called it, the DUP. And I showed up at my graduate program and very quickly learned that, in fact, one of my teachers told me there's nobody here who can help you study episodes, health episodes. And this idea of first episode of psychosis, which is actually, as I said in the conversation a lot now. In fact, here in New York, we have a leading program, On Track New York. But because it was sort of presented to me that there weren't a lot of opportunities for that, I sort of had to pivot, at which many doctoral students have to sort of pivot. But luckily, I found some mentors in my program who helped me to study an adjacent topic. And I squarely, really engaged that literature. And that was the transition to adulthood, specifically among youth aging out of foster care, because there was a faculty colleague who had a longitudinal study going of collecting data of these young people from their 17th birthday to their 19th birthday. And so I dedicated my work, my early work, to studying the social relationships in those young people's lives, particularly their natural mentors. And so, then it was sort of a, a series of welcomed accidents that happened that led me to be able to kind of find my way back to that original work in young adult serious mental illness. So I think I would encourage, doctoral students also to be open to having to pivot.
That's what I was going to say. Is that the biggest piece of advice you would give to doctoral students, especially those starting out in building their interests and working on dissertation ideas, et cetera?
That and also something else I really learned the hard way was that um, you know I could really learn a lot about the scientific process and methods, even from mentors who were studying areas completely different from my own. And so I would also advise students to be open to projects with teachers where you could learn a new method, a new skill, that way, and also maintain your bullseye on your why. Why did you know, um, come into doctoral training in the first place, and then kind of try to hold those two things at once. But, be patient. Um, you know, and sort of recognize that the careers are long and just to not rush it.
That's great advice for all of us. Take your time.
Take your time. Yeah, exactly. Just generally.
Are there questions? Victoria, I saw your hand go up first, and then Courtney. Professor Victoria Fry.
Thank you so much. That was a fabulous talk, really clear and very interesting. My question is about the Just Do You mediation model. And you said it was engagement, not attendance, but engagement that mattered to multiple outcomes, including recovery. So how did you measure the engagement? Was it is it a standard measure? And I ask because I literally came from a research methods class where someone asked me, in these, how do you measure engagement in a group? And I was like, I know someone has done it.
Thank you for that question. What a great question. So I really went on a, um, thank you. Thank you. I went on a quest to find measures because actually a very impactful scholar in the engagement literature, Dr. Mary McKay, has published about these very issues that people show up one time. But you can read in recent systematic reviews, in fact, that there are very few studies that measure anything other than attendance. And so while I was on this quest, I came across a measure from the child welfare literature. And this measure really was looking at multiple dimensions of engagement. I think maybe 5 or 6 things that we often think about, the therapeutic alliance. But the ones that I thought were particularly innovative and useful to the work in mental health services were the therapeutic alliance questions, and then this dimension they call level of involvement or your buy-in to the program. And so this is a continuous standardized measure that has been used in multiple studies. The first author is Yachmanoff. And we first did some early studies just to see if the measure, would land and see what our statistics were with it related to, inter-rater reliability and, the sort of items. And so those studies really helped us to decide to bring it in to this larger trial. But we also wanted to maintain the tradition of attendance. So
So yeah, look that measure up. And a few others are now using it. And as I said, there's many more items. We use 8 out of what I think are maybe 25 items. Yeah. Thank you.
Professor Courtney Cogburn.
Hi, thank you. It was so nice to get a deeper dive of your work and draw from our conversation earlier where you were saying you didn't start off as an intervention scientist and that you really built this foundation that informed that work later. And it's beautifully demonstrated here. So
Thank
thank you for
you.
sharing it. I just wanted to offer a couple of thoughts that we didn't get a chance to talk about related to the technology in social work piece. So one is I think that the curriculum, right, is an important place to intervene, that we have to introduce our students to what these technologies are,
Yes.
what the concerns and dangers are, but also where the possibility lie,
Mm.
and give them an opportunity to start thinking as students. One, how will they advocate and protect the populations that are going to be most harmed by these technologies?
Yes.
But also, how would they use them? How would they leverage them in their own work? And so I think there's some important opportunities there.
Mm.
And I just wanted to
Yes.
speak to the technology and human connection piece
Mm.
because I don't always see them as being diametrically opposed, right? That there are ways in which technology can enhance human connection. And I just want to shout out one of my former doctoral students, she's gone now, Chelsea Allen, who's at Rutgers, who has studied social media engagement during COVID and analyzed chat room discussions to see what types of language people were using about connection and community and healing. She's done focus groups with people to see what kinds of spaces would they design for themselves, for the communities that matter to them, to promote their own healing
Yes.
and mental well-being. So I think there's so much possible, and that's a social worker's thinking, I think, about how to use technology. So I think our brains applied to technology are so important.
Yes.
And I think there's ways that they don't have to be in opposition to each other, although they can be for sure.
Yes,
Yeah.
yes. And the only thing I would add to that is that, I think in addition to educating our students, I'm finding in what I'm reading and in talking with families, we need to also help families and parents in particular to talk to their children. And so we're using a term informally in our research group of technology hygiene, like sleep hygiene, when we think about mental health, to consider different kinds of ways to even help youngsters think about, okay, well, because I'm hearing about young people who are going to bed with 3 screens on, and young people who have addiction. And so I totally agree with you. And I hope we are at the table in those conversations for both our students, our MSW students, our PhD or former PhD, to keep moving this forward, and also helping parents to be in positions of power to teach their children, et cetera. But it's so complex. Yeah, so thank you so much for that. Yeah.
Dean Melissa Begg.
Thank you for a fantastic talk and for the work that you're doing that is just so critically important now
Thank
more
you.
than ever. So many things I could ask, but what I wanted to ask you next is to comment on this this notion of epistemic justice, which I found particularly intriguing. And I just wondered how you may or may not be at the stage incorporating that into teaching, working with doctoral students and other students in research courses. I don't know if that's come up for you yet, or if you want to focus on the research, but anyway, I just wondered how you were thinking about that.
Yeah, I appreciate that question. And it's as I presented, it's a new part of what I'm thinking about. And I was introduced to it by a colleague who wrote a very compelling autoethnography, where she was sort of discussing, the importance of being able to be a knower and be a credible, knower, even if you have experienced, the problem that you're studying. And, how I've so far been engaging in that is I teach a course at the NYU Silver School of Social Work on theory construction.
And we build from our philosophy of science course. And so I start out kind of like bridging that course to my course. And I have a whole class where I assign a lot of these writings on epistemic justice and encourage us to talk about this question of genuine collaboration and involvement with people with lived experience of the problem you're studying. And the other end of that continuum, as I mentioned, being, you know, these kinds of tokenistic invitations to be part of research. Or I mean, this has been written about by many scholars, but really asking new doctoral students to challenge themselves about that, right? And to think about that, because I mean, you could think about these questions, and we talk about this, right, as it relates to like who gets to develop the psychometric measures we use, and who actually are the architects of the theories I'm even teaching in that class, right? So we often will be dialoguing about that in a way with the frame of Fricker and others to help us to sort of question and challenge. So that's the main way. And then I have been invited to give a talk because my wife and I actually did an autoethnography. Hasn't been published yet. But it really also embeds the framing of Fricker, particularly she talks about two types of epistemic justice, hermeneutic and testimonial. And we're more interested, right, in this testimonial injustice and actually, what does it mean to be a mental health scholar studying mental health services when you live with a mental health condition? And what happens to your credibility the minute you tell people that? Right? And so we're talking a lot about sort of how is that, considered in the academy? How is that considered? Is it even spoken about at all? Is it hidden? Is it, something that we need to feel, unsafe about talking about? And so I hope that that work will build on the work of Dotson and Samuels and others to really think about this idea of being able to be appreciated for your credibility of actually maybe having, been in the hospital yourself, or having been, in treatment yourself. And then the other thing I'll say, that I think is important that I think about is related to this is that I talk with my lab and I think about the importance of team science as it relates to this, because, I think when you do have an insider position, it can be very helpful to be working, as a team so you can guard against, for example, confirmation bias of your experiences or something like that. So those are the main ways, but I hope to do more of that in the future. Thank you.
Are there any questions coming in? Because I have a few more.
Yeah, we have some questions from our Zoom attendees.
Okay.
So the first one is from Dr. Emmy Kapadia. So this is Emmy. So thank you. I have been following your wonderful work for many years. It's a pleasure to hear your talk this evening. I am very interested in learning more about the outcomes of hope and self-efficacy and how we get at these seemingly very important factors. Are these still outcomes you look at?
So, great question. And I agree that hope is essential. Hope is transformative. And we know from histories of social science that hope is extremely difficult to change. And so I want to shout out again my colleague, Kiera Moore, who has really spent a lot of time in the field working with one of these PROS programs that we did the original trial with to actually develop components that are specifically geared toward, in her work, developing stronger ethnic identity and cultural pride as it relates to mental health, and also thinking about and understanding how you're navigating your neighborhood. And so she is, but we work together on this project, still trying to figure that out. And we don't have the data from that study yet, but we are definitely committed to it, in the Just Do You line of work, but also just generally in the research that we are doing. And I have some new work going on. I think I told Dr. Victoria this at breakfast, that I'm doing a new project with a colleague at Wayne State University on middle age, because now I'm middle age, middle age recovery. And we are very focused in that study in trying to understand women's narratives and where is hope and where does, these moments of hopelessness, reside. So those are the areas that I'm thinking about that.
Okay, I have a few more questions. One of the other things that we've been thinking about is the interventions that you've developed. What would you say are maybe the one or two big takeaways that for new intervention scientists or people who are really interested in creating programs that are effective and feasible and acceptable, what would you say are the big one or two takeaways from what you've learned so far?
Thank you so much for that question. I mean, the first one that I would immediately say I've learned is just the importance of listening to the communities where you are aiming to develop programs and trying to be helpful. And that sounds really simple, but I think it takes a lot of patience, and it takes even the willingness actually to when a community shares with you that they're not ready to do this work, they're not interested in doing this work, listen to them. And that's, in different moments when I've had different stressors, like that's been easier or harder, but that's a main takeaway for me, because both in the formative work in Ohio and even working with the PROS programs, I think the reason we have been able to, just even move forward the work, but then lead to a program that has some efficacy and some promise is because there has been genuine listening, and even things that have been painful for me. Like, for example, in the first iteration, I had 2 sessions on CBT, and the young people just told me in focus groups, we don't need to talk about CBT twice. And, things like that, we changed the program. And, other elements that you don't always want to hear as the interventionist, but it's critical to do that. Also, some of the PROS clinic leadership told me, you can't do a 12-session engagement program. We have to think about this as a shorter program. And so along with mentors and colleagues, my 12-week baby is now a 2 90-minute module program that's actually potentially usable. So I think that's really important. And I guess what would kind of go along with that, just as I'm talking, is just don't be too precious with your ideas, which is very hard early on. It was hard for me, clearly. Yeah.
We're running a little short on time, so maybe I'll ask one more question and I'll turn over to Dean Begg. Oh, if there's any other questions online, let me know.
Yeah, we do have another, 2
Okay,
questions, but
Megan,
yeah.
okay.
go on.
I was also wondering, just in the current climate, politically, socially, where we are right now, what do you think are some promising new directions for you young people and mental health and well-being? Just again, given everything that's happening right now, um, how do you integrate current climate issues with, the discussions about hope and
Yeah,
well-being? So,
yeah,
what are
that's
you
a big
thinking?
question.
Well,
You
you only
wanna
have
answer
30
that first?
seconds.
No, I'm just kidding. I will just say a couple of things. So obviously, a couple of them are kind of what I ended with. So technology, targeting, those are a couple of things. And then I think, I'm very aware that not only young adults, but we are all experiencing day-to-day life in such a challenging way right now. And I think that we have to be considering, as we move forward, I believe, programs and services that really are aimed at prevention of, right now in this moment, I'm thinking about PTSD. And can we create spaces for young people, whether they're online, whether they're at a community organization, where young people can come with the kinds of fears and terrors and actually, not only feelings, but truly being erased and visibilized, and be with them in that suffering so that they don't develop PTSD. I think that's something that is on my mind a lot. I don't have any answers about that, but I think we are potentially going to see a lot more people with you know, the symptoms and the inability for them to resolve and the kinds of things we see with the emergence of a PTSD diagnosis. And so those would be some of the things in addition to technology and targeting.
But certainly your work is turning towards hope in so many ways.
Yeah.
And so there's definitely a light that we
Mm.
can look for.
Thank you. That
Um,
is such a nice way to end. That is really a nice way to end, and I think I'll say one thing related to that, which is also in this moment, which is a really tough moment for people living with serious mental illnesses. I think we need a lot more people who youth can look to who live with serious mental health conditions, but are doing well, to give that hope, to show that hope, and to show that people with serious mental health conditions are not the myths you're hearing on the media, are not the myths you're hearing in reports, because that's how we will actually, I think, create more hope for folks.
Beautiful. Thank you so much.
Thank you more.
I'm going to turn it over back over to Dean Begg, who will give us a few closing comments.
I'd be happy to. And just so great to see these two mental health experts having this conversation after a really wonderful talk. So thank you, Dr. Lanza, for your terrific moderating. And thank you, Dr. Munson, again, for a spectacular talk and a great Q&A session. Really, really thoughtful responses to everything. I guess I come away with this. There's sort of three things on my mind, if I could share them with you. One is the image of you walking Raphael from the adolescent to the adult unit, and that as sort of being an image, an emblem of the kind of work that you do now. I don't think I'm ever going to forget that. So thank you.
Thank you.
Secondly, folks here know I'm a data person. I love the notion of using data to promote equity. So I'm really grateful to you for that too. I think you've shown us how that can be done so
Thank you.
thoughtfully and ethically. And finally, through the way you closed us out with keeping human connection at the center. That's a true social work message, and we do need to embrace technology, and we do need to know what its pros and cons are. And there is no replacement for for the human relationships at the center of it. So I want to thank you for all of that. And another round of applause, I think, for our speaker.
Thank you for the invitation. Really been delightful.
Thank you for those online. We're out. Thank you again.